Good evening and welcome. As most of you know, I'm Craig Snyder, and joining you this evening for the last time as CEO and President of the World Affairs Council of Philadelphia. I want to thank all of you for being with us for this, our second annual healthcare focused program in partnership with the Philadelphia College of Osteopathic Medicine and Independence Blue Cross. And thank both of them for their partnership with us. I'd also like to thank the Giant Company for partnering with us on this year's program as well. If you have any technical issues that come up during our broadcast, please use the questions bar, and the Council's Vice President for Programs, Haley Boyle, will help as best she can behind the scenes. And then later in the hour, we'll take some questions from this audience. In order to ask a question of our speakers, please just type it into the questions bar. And if your question is selected, I'll read it out loud. So with that, let's turn to the program at hand. We're joined this evening by Nick Bertram, President of the Giant Company, by Sue Doherty, registered dietitian, nutritionist, and the CEO of MANA, the Metropolitan Area Neighborhood Nutrition Alliance, Daphne Klausner, Senior Vice President of Senior Markets at Independence Blue Cross, and Dr. Barbara Williams-Page, a primary care provider and Associate Professor in the Department of Family Medicine at PCOM. I'd like to ask each of our panelists to make a few opening remarks, kind of set the stage for what they see as the most important aspects of the topic that we'll be considering this evening. And we're going to take them in the order in which I just introduced them to you. So Nick, take us away.
Thank you, Craig, and good evening to all. I hope that you're safe and healthy wherever it is that you're joining us from tonight. As Craig mentioned, I get to work with 35,000 awesome teammates at the Giant Company. We grew up in Carlisle, Pennsylvania, started out in 1923 and have been growing ever since. And, you know, throughout the time of our founder, the Javich family, to up until today, now that we're in 4 states, investing in conversations such as this one has always been important to us because not everyone who has, you know, access to Giant actually has the ability to feed themselves. And hunger is real. Hunger is a problem. It continues to impact 1 in 4 children in America today. They don't actually know where their next meal might be coming from. And that's the reason why we've worked so hard with partners like Feeding America or Fill Abundance, food banks, food pantries. All of these areas are very important to those who are malnourished or don't have access to food or don't have the ability to have that. But I got to tell you, since this pandemic struck, that work that we've done for a while now has really been under a microscope that I didn't expect. I don't think I fully appreciated what it meant for these children who depended on school assistance, what it meant for these families who really were not going to know where paychecks were coming from, or where assistance was coming from. I didn't know exactly what it meant until the pandemic. And in Philadelphia as a region, but also in the state of Pennsylvania and really across the world, people are dealing with malnutrition. People are dealing with insecurity in food, and they're also dealing, though, with a lack of education, honestly, in what good, healthy food looks like. And so our heart beats strongest for kids. It's one of the areas that we are really trying to work hard to help out in. And it's one of the reasons why we've partnered with CHOP and created a food pharmacy. And I'll talk about that maybe a little bit later on tonight as well. But it's just one of the examples of how you know, food is a determinant of health. So delighted to be with you tonight and to join these fantastic panelists. Back to you, Craig.
Thank you. Sue?
So good evening, and thank you so much for having me. I'm so honored to be part of this panel discussion and excited to talk about the work that we're all doing in the field. So I'm with MANA, which MANA is celebrating our 30th anniversary as an organization. We are all about food as medicine. And so really our focus of our work is making sure that people that are battling serious illness get access to the right nutrition. The reality is, though, the 1,500 clients that we're serving today, over 90% of them fall below poverty. And so as a dietitian who used to work in the field as a dietitian, you know, one of the major barriers over time is that you're meeting with folks, you're counseling them, you're providing them education. I would have my food models, you know, in my hand and showing people the appropriate nutrition. But the reality is I knew that folks were going home and they just didn't have access to good nutrition. So at MANA, we were all about policy and advocating that when people get prescribed diets, that they get access to that. And that's something we're so passionate about. It's frustrating, right? Since diets have been being prescribed since at least the 1960s. And we're not just talking about, oh, you know, you need to go home and like eat better. We're talking about diets that are carbohydrate controlled, 4 gram potassium, 4 gram phosphorus, 2 grams sodium restricted diet. And folks leave the healthcare systems and they go to the pharmacy for the medication. They go somewhere for physical therapy, rehabilitation, for chemo, radiation, but folks don't know how to access the right nutrition. And so we kind of at MANA, we say we are the pharmacy for your prescribed diet. We're serving 1,500 households today. We're producing about 1.5 million meals a year at no cost to our clients. It's complete nutrition. So we provide 3 meals a day, 7 days a week, delivered once a week. If our clients have children in the household, we make sure that everybody under the age of 18 gets complete nutrition as well. And also if they have an elderly parent, maybe that they're the caregiver for, we just want to make sure that the household is taken care of so that our client and their health needs are being addressed and, you know, not being distributed throughout the household. We definitely see the health disparities, right, throughout the clients that we're serving, race disparities that are included with the health disparities. Over, you know, 70% of our population are Black and brown individuals. And we just see that the diet-related illness, obesity, hypertension, cardiac disease, over and over and over again. And so we are so focused on making sure that someday that everyone has access and looking also how we work within the food sector, right? So we're not a forever program. So how do we do the handoff to the food pantry programs, to the prescription RX programs? And certainly, you know, to echo what Nick said, COVID has certainly heightened this. We've seen a 40% increase in need for our services. We've seen some recognition for the importance of our service, so we're hoping to continue that momentum. But there's a lot of work to make sure that we can address, you know, the whole continuum of care and not just a piece of care. So thank you.
Thank you. Daphne.
Yep. I'm Daphne Klausner. I'm the Senior Vice President of Senior Markets at Independence Blue Cross, as Craig mentioned. Nick said his heartbeat is for kids and my heartbeat is for seniors. So in particular, our focus at Independence Blue Cross has been to work through food insecurity as it relates to seniors. We were able to last year, in partnership with Sue's organization, start delivering meals to seniors. It was probably one of the most exciting things that we as an organization were able to do for our members. It was connected to a hospital discharge, certain conditions, and Sue's organization was able to provide meals for 4 weeks upon discharge. And we're really excited to actually be able to see the data now on the health outcomes. And I know we're going to talk about that a little bit later because there are significant health outcomes to getting proper nutrition consistently over a long period of time after you're discharged from the hospital. And I'm sure Dr. Page can talk to that as well. But at Independence, one of the things that we feel privileged to be able to do is because we are a Medicare Advantage plan, we have been permitted to offer as part of our basic benefits food to our members when they qualify. With regard to the pandemic, one of the things that we also saw as another privilege, one of the first things that came to our mind when everybody went into lockdown and everybody began to suffer from food insecurity in ways and how they were going to get their groceries because they were afraid to go out, that the seniors were going to be the most impacted. So Sue actually wasn't able to fulfill some of our needs because they were so busy with other things, which is great for them, but we were able to partner with another organization locally to deliver groceries. We delivered groceries to about 1,200 Medicare Advantage members over 4 weeks. And we actually just started doing it again for some additional members. So we're really excited and privileged to be able to deliver those kinds of benefits to our members. Excited to be here. Thanks, Craig.
Thank you. Doctor.
Thank you, Craig. Not only am I honored to be a part of this panel this evening, but I'm also honored to be a member of the Philadelphia College of Osteopathic Medicine. Craig, as you stated, this is not the first year that the Philadelphia College of Osteopathic Medicine has partnered with this project that you are doing. And this goes to show you that the Philadelphia College of Osteopathic Medicine is very community oriented. So as we're taking care of our patients and providing care in an office setting, we're also out in the community trying to assist with the patient care. And you all on this panel represent organizations that have direct impacts and great resources on the patients that we do care for. And I'm looking to even to learn more about the resources that you have that I can offer even more to the patients that we care for on a daily basis. Thank you.
Thank you. Thanks, everybody. A great start. So the best estimate that I've seen is that there are approximately 16 million Americans who live in what have been classified as food insecure households. So that would be about half of the number of Americans who are counted as being in poverty by the federal government, about approximately 5% of the US population. So first I want to ask whether or not you think that's a reliable number to the best of your information, because there are lots of statistics that one can find that sometimes are not so reliable. And secondly, if it is at least a decent approximation, what would account for half of those in poverty being food insecure while the other half are not, right? So is it a question of, well, the food insecure are simply the poorest of the poor? Or is it a question of SNAP and other benefits, federal benefits to which people are eligible, not everyone taking advantage, or not everyone knowing how to take advantage of benefits that they're eligible, or maybe there's some other sort of explanation. So I wanted to kind of start, let me start with you, Sue, on that, and then we'll kind of go around and see what people think.
Sure. So that's a big question, right? And something that we talk a lot about here at MANA. I definitely think the statistic you shared is, it's a statistic that's the statistic that's out there. It's not certainly the population that we're seeing, right? The population we're seeing, 90% are poor and struggle with food insecurity. So I think there's a lot of things that factor into that. I think a big part is accessibility, right? So what do people have access to? Where are they living? Transportation, services. We try to connect our clients a lot with benefit status trust to get people connected with SNAP and benefits and so forth. It's not easy, right? And so once you go through that process, you also then have to recertify. So it's not like you get certified and you're good. So I think accessibility, I think your social capital, right? I think your network of connections and community play a big factor to that. And then I think also, depending on where you're residing, I think, access to free lunches and free breakfast through school programs, I think play a big factor in that. I think in Philadelphia, I think all kids have access to that. I don't think that's true across the country. So I think that, access, transportation, and then really just the assistance to get tied in. I mean, to one of your points you mentioned earlier, I mean, we know there's absolutely data out there that shows people that qualify for SNAP benefits, a large proportion of those folks are not receiving SNAP benefits. So I guess I can't say accessibility enough. I'll open it up to those others.
Yeah, I mean, I guess I can comment on what we see in our population at Independence, and we have about 38,000. If I think we have about 90,000 members, 38,000 identify as food insecure, and that's just in this area. And I think not only is food insecurity an issue, so access, but I also think there are other complexities from a social services perspective that are feeding into that. So whether it's lack of transportation or they're living alone, as I mentioned, we serve a lot of seniors. They're living alone, and maybe it's just too much to go out, even if you could walk to a store, but it might be just too much to do. If there are other conditions, whether it's depression or some loneliness, that may be actually even impacting you, that you don't want to cook. So I think there's just a lot of complex conditions that are all feeding into this food insecurity issue that we're all seeing. So that's.
Daphne, you and Sue mentioned in your opening that you two collaborated this summer in delivering food to our senior patients. I think that is such a great project, because when we talk about food insecurity, we just think about accessibility to quality food, but we do leave out transportation. We don't factor in transportation. We also have to factor in disabilities. So patients may not, or patients may not be able to physically get to a location because of their disabilities to even access some of the resources that are in the community. So we do have to factor that in. And I think the project that you two did, that you collaborated on, where you delivered the food, that was great.
And we continue to do that. We actually started that about a year and a half ago, and Sue's organization does tremendous work. I mean, in addition to using them to deliver food to members who need it when they're discharged, we actually do volunteer work with their organization too. And I've personally cut a lot of potatoes, so it's really been a great partnership.
We've kept the onions away from you.
Yeah.
It's been a tremendous partnership with that.
So what I'm hearing is that food insecurity is a more complicated definition, right, than people might assume. People might think it's just sort of absolute lack of food, lack of calories, lack of nutrition. So you have that maybe as sort of like the core of the problem, but then kind of one layer out from that is, well, I can get enough calories, but it's not nutritious food. It's exactly. Food that might end up making me sick. And then there's kind of this other layer that you all have added into it, that in which it's, well, I even do have access to quality food in theory, but because of disability or because of lack of transportation, because of other conditions, I can't make that last mile, right, or that last whatever, that last 100 steps to bring the food to my plate. So with the complexity of the problem being such, it seems like addressing it is equally complex. It's not one simple thing. So all that goes to a question, which is, what aspect of that kind of chain of causation do each of you think is sort of most important for public policy, right? If you could do one thing, what would the one thing be? And Doctor, I want to start back with you.
Delivery. So when I think about our seniors, when I think about the conditions with our seniors, their disabilities, their arthritis, whether it's osteoarthritis, rheumatoid arthritis, and when you see them standing in lines to gain access to some of the resources that are in the community, you see them stand in line with a cart. They have to get that cart home. They have to get that cart up the steps. Many of them aren't capable of doing that, but they manage to do it some type of way. But then I'm seeing them the next week in the office because now they have exacerbated a condition that they already had because they're trying to lift their food. So delivery as part of the resources that they are receiving would be very beneficial.
I'll tag on to what the good doctor said. One of the things that caused delivery and pickup not to be an option, especially if you had SNAP, is that you could not up until very recently access that. And so you can't go online. There are only 2 retailers in the entire country that were doing a pilot program with the FDA in order to be able to do that. That's finally changed. The pandemic has actually caused that to change. So Craig, you asked what would I like to change from a policy standpoint? It changed. And now it's just a matter of actually getting it done. But individuals having access to SNAP to buy for delivery has not been the case. And by the end of this year, I think you'll see that go across many different retailers.
And go ahead, Sue. You go.
I was just going to say, certainly from a policy change, I mean, I think a huge deal would be getting, a prescribed diet and recognized as any other prescription. It blows my mind that healthcare providers can provide insulin, they can provide a hypertensive medication, and it's prescribed for life. right? It's not like, oh, we're going to give this to you for 6 weeks and then, you know, we'll take that away and see what happens. So if a medically tailored meal is working and keeping folks off insulin or keeping them off a hypertensive medication, why can't we look at that as the same type of an intervention as we would that medication? I think that would make a huge difference in treating health disparities. I think certainly Mana's research has shown improved health outcomes with reduction in healthcare costs. And so that would be our big policy wish.
Yeah, and I was just going to add, so the Medicare program did in the last year and a half for Medicare Advantage allow plans to provide food as benefits. So to Sue's point, we have from a policy perspective been granted the flexibility to do that. The only thing I would add in, because we are talking about the complexities of the situation, is that there's a mental health component here as well that I don't think any of us have really talked about. And so when you have loneliness and depression on top of the food insecurity, and you don't really even want to go out, and you're living alone, and nobody wants to even, you know, you're not talking to anybody, nobody's asking you if you've eaten today. I think that's actually, from a policy perspective, some mental health parity around you know, food would be helpful.
So in preparing for this, I saw some substantial data really that shows that adults in food insecure households have 50% more emergency room visits and hospital admissions compared to food secure households. So my question is, you know, is that cause and effect? Or is it just some sort of correlation? Then maybe there are other intervening factors that explain the discrepancy, or is it some sort of combination of the two? Daphne, I'm sure you look at this stuff, so let me start with you.
Yeah, we have a lot of data on this. We actually have data that shows for diabetics, it costs us about between $500 and $700 more per year because of the food insecurity issues. So it's a pretty significant cost when you actually look at the number of diabetics we have, because I think something like close to 40% of our population has diabetes. So when you look at those costs, it is pretty significant, which is why we partnered with Sue's organization, because we know that those kinds of triggers, once they've had an inpatient admission or a SNF admission, et cetera, and then they get discharged and they're diabetic and they're not getting the right care, they could end up right back in the hospital or in the nursing home. So there are direct correlations that we see around utilization directly related to food insecurity, absolutely.
And so, Craig, when you talk about the food insecurities and the rise in emergency room visits, Daphne, you mentioned the diabetics specifically. So with our diabetic patients, food insecurities, they may be in a neighborhood where they can't find the quality foods, but they can find foods that are high in carbohydrates, the foods that are high in starches. Those foods are going to cause their blood sugars to be elevated. The elevation in their blood pressure is going to land them in that emergency room. Or the foods may be more salty foods. Our patients with congestive heart failure, emergency room. So yes, our patients with food and in the areas where food insecurity is at a higher rate, these are the conditions that's causing them to end up in that emergency room.
So you do see it, Doctor, as a direct correlation in many cases.
Yes. Mm-hmm.
Got it.
And I mean, you often see so often that certain medications require that you take with certain foods or without certain foods, or, you know, avoid vitamin C and hydration. I think hydration is a big component where, I mean, we see often, I mean, a big component of our program is not just providing the meals, but nutrition education. And, you know, our dietitians see over and over again, hydration is a huge issue.
So, Nick, I want to come to you and dive a little deeper into at least one of the causes of food insecurity. So there may be some folks in our audience that aren't familiar with the concept of food deserts and how prevalent they are and how that can lead to insecurity and even to malnutrition. So can you talk a little bit about that idea and what your industry is doing to address it?
Yeah, it's I mean, it's surprisingly impacting millions of Americans, and you know, primarily in rural areas. If you really look at the federal definition, it's usually, I think, 10 miles access to a grocery store in a rural area. When you think about more metropolitan areas such as Philadelphia, New York City, and other places, I mean, there are food deserts that exist there. And I would be remiss if I didn't recognize a gentleman I admire called Jeff Brown, who runs you know, 7 or 8 Brown supermarkets under the ShopRite banner. And he has addressed this head on. He has a huge heart, and he's a person that I care a lot about. And it's fun to compete with him, right? Because he's doing a great thing. And he has answered that inside of Philadelphia for years. My company has answered it outside of Philadelphia in rural areas throughout the Commonwealth. We go almost to Pittsburgh and pretty far north. And then as an overall industry, I mean, there have been periods of time where major retailers such as Walmart have gone into job opportunity zones and they have answered food deserts. You see that in other players like the Kroger company and just a variety of different retailers. I think one of the things that concerns me is that many times food deserts are being answered by players such as dollar stores that don't actually have fresh produce and fresh fruit and veg. And so they'll go in and they will answer, and I use that in air quotes, food deserts in more rural parts of the world, but also even in certain city or parts of Philadelphia. And that leads to problems as well. It's not just not having access to a proper grocery store, but it's also having access to food, as the doctor said, and as Daphne said earlier, filling up with things that just aren't healthy. And that's where education comes in. That's why the work that Sue does and nutritionists across the world do is so terribly important, but especially for impoverished areas. It's impossible to look at food deserts and poverty and try to pull those apart because quite often they go into one another. And so answering food deserts is complex. It takes support from government, it takes support from developers and private businesses, but it also takes, you know, a heart to solve that problem for customers. One of the things that gives me courage, and it was mentioned earlier, is the ability to use delivery services to answer food deserts. Because even if it doesn't make financial sense to go into specific, like, you know, population areas, maybe you can't find a building that works, or maybe the crime rates inside of that area prohibit investments inside of it, you can use delivery as a solution to that. And I see a lot of players doing that too. So can turn it back to whoever.
Yeah. Nick, may I ask, are there any areas in Philadelphia that meet the criteria by your definition as a food desert?
You know, it's a very interesting question. Our strategy team just did a zip code survey very recently. If you go to zip code level, you don't really see it, but you have to go block by block, and we haven't gotten to that level of definition just yet. My belief is that Jeff has answered a lot of those, and also by the technical definition, you have grocers whenever you have like a Dollar General or one of these bodegas, they just may not have, you know, then it's not access, it's like financial access. Sometimes the prices are just way out of bounds for items. I mean, you can see products really being overpriced in some of these areas, and that's the same thing as a food desert. It may not technically be one, but if you can't afford it, you're not going to buy it. Instead, you're going to go to the processed foods and just fill up on something that's sugary.
So I'm very familiar with the North Philadelphia area, and as I drive through the North Philadelphia area, even though there is a ShopRite in the North Philadelphia area, there's still some sections where if you don't have transportation, you can't get to that particular ShopRite. But yet on every corner there is a convenience store, and you see more and more of those small independent grocery stores opening. But then you find that the food prices are much higher. The quality of food is not the greatest, nor do they have a wide a variety selection of food
Right.
in those stores. But that's the only locations that the patients can get to.
No, you're exactly right. I can think of some other neighborhoods as well. And it's one of the reasons why our company is investing in Philadelphia. We've opened 3 small format stores in urban areas. We have ambitions to do more of that. There's some projects we haven't announced yet that'll go, you know, across the city, but providing access not just to the food, but to affordable food. I'm very proud of the price position that we have in fruit and veg. Specifically, we've invested in that because we believe that it's, critical to our customer needs.
And one of the things that I want to compliment that I think is happening more and more in larger grocery stores is access to dietitians for education. Back in the day, a long, long time ago, when I was actually going to school to be a dietitian, I worked for a supermarket chain for many, many years, and it was so interesting and also sad that the customers knew me and knew I was going to school and would come up and they would be really proud, right, to say like, oh my God, look, Sue, I'm buying this product, right? No sugar at it. Well, meanwhile, it's like a blueberry pie with like 1,000 grams of sugar, and it's just no sugar at it. And so I do think it's hard for a consumer, even if you have good intentions, to know like what is a healthy food product. And so I know a lot of chains have moved to providing education and having dietitians in stores, which I think is great.
I might also make a plug. There are a lot of really terrific organizations. I'm just going to name one of them, the Food Trust, that's bringing farmers markets to various places in the city. And those farmers markets now accept SNAP benefits. A lot of them are allowing seniors to shop earlier. So I think that's another really tremendous new add to the system for people who live in food deserts to have those farmers markets. Again, not everywhere, certainly, and I think Nick is right. It really is a block by block thing in Philadelphia. But there are some additional ways that people are trying to provide fresh fruits, vegetables, etc., to people in the city. There's some that are really large, like Clark Park, that are really providing the neighborhood with some really good opportunities.
So, Nick, you raised Jeff Brown and his stores. I'm sure and some of our other panelists may know that at least some of those stores were really damaged severely in the civil unrest of the spring. That company made a commitment to rebuild and reopen, which I'm sure most of us would consider really commendable. But it does raise the issue, as you said, about sort of the economic viability of bringing major markets into a lot of areas. Can you talk a little bit more about how you think delivery might be kind of another option? And when you combine that with what we've heard this evening about people not being able to, as I said, sort of get that last mile or even less than a mile because of physical or other disabilities. Again, delivery sounds like a solution to some of that. So how can the sort of the range of delivery options be extended to more and more people?
I think I mentioned one of them earlier. It's making sure that all of the tenders are able to be accepted. Most organizations are just cash and credit right now, but to have electronic benefit transfer is critical in order to make it viable for those who are insecure. And that's happening. That is in motion. And for my company, we'll be complete with the programming, I think, by the end of October, early November, which is record time, actually. So we're happy to knock it out. But there are other providers that will do that. One that we utilize is Instacart. Uber Eats has recently started to go after. There's a lot of different, there's even smaller independent ones that have popped up, more entrepreneurial inside of Philadelphia, which are cool to watch as well. So that it's not that there's a lack of options for those, Craig. Like there's a lot of different delivery services that are probably out there, but sometimes you have really like you'll have a minimum basket of like there's one grocery I know that's like $120 minimum basket. That doesn't work, right? Like that's going to immediately put some people out. And then you have some that will have exorbitant delivery fees. And so there's a lot of work that goes into that. What's one of the good things that has come out of COVID-19 is an acceleration of the acceptance of e-commerce inside of the food and the grocery sector. And so you're seeing, we're seeing penetration rates now across the industry that we honestly didn't expect to see until 2025. So more people are taking access or advantage of that. And I think that is going to help out in different areas. The downside to that is that you also have the exact same service for fast food. And so if we're talking about food as medicine and food as a determinant of health, it's not just access to the food, it's an education on what to feed your body. and what to put into your body, which is what, as Sue mentioned, dietitians are so critical. We have 8. I'd like to have more, and probably we will one day, because they stay quite busy in educating people, both inside of the stores and online. So,
can I ask a question, Nick? Your delivery acceleration, et cetera, which I think is phenomenal. But what about a lot of those delivery services require somebody to have access to technology? So how can you talk a little bit about how you might do that, since my heartbeat is for seniors?
Yeah, it's a very interesting question and a bit of a problem, because by the very nature, it's not really the catalog service, right? It's not the dial-up service. I can tell you one solution that we did inside of Lancaster. There's an area in Lancaster which was an impoverished area. We decided to put a distribution center there, an e-commerce distribution center there. And we heard loud and clear that people did not have access to technology, some of the individuals there. So we actually put a pickup section that you could walk up to, and it actually had computers inside of it. And you could just order right there, and we would have a staff member able to help you out. There's probably other examples that need to take place. That's the only one that I can offer at the moment. But I hear you, and definitely if I look at our customer base, I hear it from our customers sometimes. There's so much that's going digital right now that can feel like you're being left behind.
So, Barbara, I want to come back to you. You gave us some examples earlier of how you see in the emergency room conditions that need to be treated that you think can be directly directly caused by food insecurity. And I wanted to kind of tease that out a little bit and have you talk a little bit about what do you think the adverse health outcomes and higher healthcare costs are that you as a practicing physician can attribute to this issue?
Sure, Craig, thanks. So Craig, as a family medicine physician, we encounter patients on a daily basis with hypertension, diabetes, hypercholesterolemia, obesity. Now, all of these medical conditions can, and in most cases, they lead to heart disease, renal kidney disease, vision impairment. So now, and that list goes on and on. But now, in addition to that patient with hypertension, diabetes, hypercholesterolemia, obesity, in addition to them seeing me as their primary care provider, they are now being followed by cardiology, ophthalmology, nephrology, endocrinology. If insurance permits, they're going to be seeing Sue as the dietitian. So you see what's happening. The healthcare spending is going up. Now, there's a commonality with all of the diagnoses that I just mentioned, and that's diet and exercise, but diet. But as we're giving the patient, as we're discussing their plan with them during the visit, we're discussing the things that they should eat, the things that they should not eat. But of course, the things that they should not eat are the things that are readily accessible to them. Now, I think one of the things that we're not doing a great job of in the office setting is talking about this term, food insecurity. So we are we're educating the patients and telling them what they should be eating, what they should not be eating, but are we asking that question, do you have access to these foods that I am recommending you to eat? That question may not be, I don't think we're asking that question directly. And the patients are not offering the information to us. They are not admitting to us that they don't have access to this food. So I think we may need to form some more partnerships to open up that conversation with our patients.
So Daphne, it sounds like there could be certainly a role for the insurance providers in what the doctor was discussing, right? It is certainly in the interest of controlling healthcare costs in addition to better outcomes. to have patients be able to learn about nutrition, be counseled by nutritionists, as well as to have the other supporting services that would help them actually access the food. So are there ways in which Independence Blue Cross and other insurers are really trying to bridge that gap?
Yeah, so I was just going to say that we are trying to bridge that gap, because I think everything that she mentioned obviously revolves around diet. But again, as I said earlier, it is not only diet. There are so many complexities involved in food insecurity around transportation, housing stability, depression and loneliness. And we just talked for a second around technology, and literacy around how to access the benefits or the services that you need. So I think there is a real need. I know we at our organization have just launched a new partnership called Community Link, which is trying to connect a number of different social service providers to be able to talk to each other about when we have a patient or a member, however you want to refer to it, who has needs beyond the clinical, because I think historically these were clinical needs, but now they're social determinants of health. And I think the insurance industry and the provider community are beginning to realize how critical the two really are and need to be addressed holistically for the community.
And I would just jump in and just say that one of the things that we see over and over again at NANA, going back to compliance, right, and healthcare costs and health outcomes, are, when clients come onto our program, they're not picking, right, what we're sending them. And probably the first week, maybe, they're not foods that they're familiar with, and it wouldn't be what they would choose. But 6 weeks into our program is usually when we get the phone call or we get the letter from one of our clients that, I'm going to use their term, but they'll, it's, oh my God, I went to see my healthcare provider and I didn't get yelled at, right? And they were told for the first time, like, what are you doing? Your blood sugars are looking good, your high blood pressure, your blood pressure has come down. And that is when you can really get long-term behavior change. And we see it over and over in our outcomes where, the first couple of weeks, maybe clients are a little hesitant or a little, resistant to the regimen. And, it's a really strict regimen. We have 12 different diet modifications, but a lot of our clients are battling many comorbidities. So they may be on a combination of 3 different diets. But that's the moment, right, when they connect with their healthcare provider. And honestly, quite honestly, they're more prone to go see their healthcare provider when they feel good about that they've been taking care of themselves.
So we have a number of questions that have come in from our audience, and I'm going to turn to those now. The first question says that the city of Berkeley has become the first city to ban junk food, the sale of junk food in grocery stores. How does our panel feel about that becoming a more prevalent policy in different areas? So let me start with the grocery store guy.
Yeah, I'm a pretty big free choice kind of person. I think education is more important than restriction. I just think about raising my children. I can restrict them from everything that's bad, or I can teach all 4 boys to do the right thing. That's the approach that my wife and I are taking, is to teach them to do the right thing. I believe the same is true in food choice.
When you ban junk food, you have to define what is junk food, because they can ban the sale of potato chips, but if you eat enough potatoes, it's just as bad as eating potato chips. So again, back to the education. So yeah, you can ban one thing, but then a patient will increase the consumption of something else and get the same negative result.
Okay, I hear no votes for junk food bans. Going once, going twice.
All foods fit.
Yeah.
Okay. Next question is about the role of schools. A couple of you have mentioned the free lunch and free breakfast programs. So I mean, how central are the schools to our nutrition system? and therefore, how badly have things been disrupted by the pandemic?
So I can jump in and say that certainly I think the pandemic has been extraordinarily disruptive, and that we're seeing, we're getting calls daily about the need for children having access to our complete meal program, where in the past we have a supplemental meal program that was only dinner entrees only. So we've certainly seen an increase in the need. And I also think schools should play, quite honestly, a more critical function in the education component around nutrition and cooking, right? Like, why is cooking not a mandated class? And we see so often with the produce prescription boxes, that clients get these boxes and they don't know what to do with it, right? They don't know what to make with the vegetables or the fruits. So I think, I don't know, I say over and over again that, and maybe I'm dating myself, but Maslow's hierarchy of needs and taking care of basic human needs, and even in regards to mental health, right? Like, why is that not something that's checked out on all of us at least once a year? But I do think nutrition, I think education, I think physical activity. I mean, I went to Catholic school and I was really overweight, not healthy, a young child, and I was really thankful that I didn't have to do physical education or exercise, but it should be part of the daily regimen, and it should start at a really young age for all kids.
Yeah, I agree with the education portion, Sue, that you just mentioned. It's great to have the more nutritious lunches and breakfasts at school, but I think teaching the kids the reason why they're being served, what they're being served, is going to help them not just in school, but it's going to help them at home and make better decisions at home. It's going to help them if they stop at that corner store on their way to school to make a better selection, a better choice at the store when their parents are not with them.
I would offer two builds. I think it's surprising how much children depend on food from schools. And one of the needs that arose a couple of years ago is a backpack program for weekends, where kids were eating Monday through Friday, but then you have Saturday and Sunday, and it wasn't taking place. And so there's a number of organizations that have solved that. And the only other angle that I would offer, and it's a personal example, I mean, I grew up poor in a small rural area, and with a single parent who did the best that he could raising me and my sister, and we didn't always have good food access. And were it not for school lunches where I had to eat vegetables, I would have never eaten vegetables. The only thing I would have had would have been frozen or processed foods. And I struggled with weight my whole life, really up until probably the last couple of years, as you learn more about it. And so it's not just like getting food, it's also the education of the lunchroom staff, the cafeteria people who may not be celebrated too often, but they are doing something whenever they're serving vegetables or they're serving, milk and things like that.
So next question is a little bit longer, so I'm going to read it. Studies say that the U.S. is a leader in food waste. Grocery stores are known for throwing away billions of pounds of food each year. Is your organization or another organization that you know of working to lessen food waste and to use it to provide for those facing insecurity, especially because nutritious foods spoil more quickly and in larger quantities of these are likely to end up in landfills. So obviously, Nick, we'll start with you on that one.
Yeah, it's a personal passion, so I'm glad for the question. We today divert 86% of our waste back into some kind of useful stream. So in other words, only that which is left is actually thrown away. We have 9 stores that are certified zero waste, which means that they divert, they recycle, or they reuse, or they donate 90% of everything that would otherwise go into a dumpster. And so we're on that trip right now. It's my ambition to be the first grocery chain in America to be a zero waste organization. And a lot of that goes to food banks. A lot of that goes into reuse programs. So a quick example, rotisserie chickens. In the past, those have been thrown away, but we found a different use for them where you debone them and you create a gourmet chicken salad that goes into the deli. And so there's recovery programs that you can invent inside of fresh areas as well to make sure that the only thing that you're actually throwing away are the bones. And that's the kind of ingenuity that's taking place inside of grocery chains. Financially, it makes sense. but also at a higher level, it just makes sense not to waste anything when so many are in need.
Thank you. The next question goes to the benefits that we were discussing, SNAP and other programs. And the questioner wants to know whether or not those who have convictions for drug crimes are banned from SNAP and other benefit programs. And I'll just add to the question, there's been a lot of discussion about work requirements for these benefits. Are you seeing those kinds of restrictions have an impact on the food security issue? Anybody who wants to jump in? Nobody on that one?
I mean, I can just speak to not so much. I don't know the answer to the question about the SNAP benefits and if folks have a drug conviction, if that impacts them receiving benefits. I can certainly talk to on the side of hiring, right? And so and helping to keep folks out of poverty. There's definitely restrictions around who you can hire if they're directly in line with a client face to face. But certainly, MANA really does try to, not look at criminal history and not hire folks that are not having direct interface with clients because of a background check. But it's challenging, certainly with contracts and who you're working with and what the demands of the contracts are you're working with.
So I think pretty much everyone on the panel has talked about the beneficial effects of SNAP and other nutrition programs. So I guess the question I'd pose that sort of comes from that last question is, what would you say to somebody who said, well, if taxpayer dollars are being used to help someone, there need to be requirements. There need to be eligibility requirements, and one of those requirements should be that if the person's not disabled, that they are either seeking work or seeking education in order to, at some point, theoretically, not have to use these taxpayer resources. How would you sort of respond to that argument? Daphne, let me ask you to try to field that.
Yeah, I mean, this is a difficult one to respond to, but I don't believe that anybody doesn't want to work for what they're taking in. That people want to work for their benefits. So as much as there are people who believe that people are lazy and things like that, I don't believe that that's true. I think there are all kinds of situations that prohibit people from keeping jobs and sort of living as best they can and fulfilling their potential. So I don't believe that we should put those kinds of limits on, because I think for a lot of people, I mentioned mental health before. It's something else, and I know Sue mentioned it too. We should all be asked every day, how are we feeling? Because there are so many mental health conditions that then impact one's ability to keep a job or just maintain a healthy lifestyle. So I don't personally believe that. So I think that.
Thank you. All right, we've come to our last question, and Doctor, this one is clearly for you. It's from a fourth-year medical student in the audience, asking how medical students should be encouraged to think differently about their role in nutrition. And the questioner asks whether or not you think that patients would be offended if their doctor basically prescribed to them to eat some more vegetables.
So patients that they are not offended because we do pretty much prescribe that. It's not a prescription, but it's part of a plan, part of our plan. So patients are not offended. I work with fourth-year medical students on a daily basis. And one of the things that I try to educate them on is how to communicate with the patient. For instance, I don't use the word carbohydrates with the patient. I use the word starches. You tell a patient to decrease their carb intake, they may not understand what carb is. But if you tell them to decrease their starch intake, they understand that. So I try to teach the medical student things like that, how to communicate better with your patient. But you can't just tell a patient to eat healthier, eat more vegetables. You have to give them examples of what to eat. And I think we have to share more resources with the patient on how to obtain those foods that we are recommending them to eat. So I think that more communication with the patient, spending not just more communication, but a lengthier communication time with the patient. It's going to take more than a 5-minute conversation with the patient to talk about nutrition.
But I would just add, I don't think that it's the responsibility of the physician community alone. And that's why, you know, there are so many other organizations that I think have to work together so that, you know, when you do have your physician referring you to healthy eating, that you have the services available to you, whether it's either delivery of food or education. And I think Sue talked about, you know, people get boxes of fresh vegetables and things and don't know what to do with them. So it is not only the responsibility of the physician provider here. I think this is a community that needs to work together to make sure that people are supported holistically to carry through on a health plan that their doctor thinks might be appropriate.
And I would be remiss if I didn't give a shout out that you know, the field of dietitians also. And I think that the field itself is so confusing. I could be here all night talking about it and the term dietitian versus nutritionist. But, you know, we are experts that go through 6 years of training. And certainly our medical providers have a lot on their plate. And, you know, to Daphne's point that, you know, it shouldn't fall just on the medical provider, that really to be able to refer to a dietitian and to have that dietitian provide the education, just like you would refer to any other expertise, I think is critical.
Well, and it's a responsibility of those who sell food also. I mean, we have a guiding star program that says 1, 2, or 3 based on nutritional value, just to try and simplify it at shelf and online and in our ads. So I think we're all saying the same thing. It's everyone has a piece of that responsibility, I believe. Sorry, Craig.
Well, thank you all for this, I think, really fascinating conversation and the way in which you've brought those pieces together for the audience. So thanks to the panel, thanks to our partners and supporters for the program this evening, and of course for all of our viewers at home. Once again, I'm Craig Snyder, and we are adjourned. Good night.
Thank you.
No,
Bye-bye.
thank you.